Mr. Smith, thank you very much indeed for coming today. It is in the recess period, and we're very grateful to you for giving up your time when you probably would rather be in your constituency. But as the chair of the all-party surgical mesh implants group, we welcome you today, and we look forward to what you've got to tell us. So it's really over to you now.
Great. Thank you ever so much, Julia. Thank you to everybody for inviting me to address you today, and thanks in particular for arranging this so that I could do, because as you know, you had to rearrange this for me to attend a funeral at an earlier stage. So I'm very grateful to the review committee for allowing me to come and speak to you today. As you say, I'm the chair of the all-party group. That's a group we formed several years ago, I think now 5 years ago. I formed it having first encountered the problem of surgical mesh when one of my constituents, a very brave woman called, came to see me. It wasn't an issue that I knew anything about prior to that. Explained her experience, which I think is a very typical experience of a woman injured by mesh, which was essentially in her middle age, late 40s, no, younger than that. I'm doing her a disservice. I think her early 40s. She had a problem with stress-related urinary incontinence, went to see her doctor. He recommended that she have a tape inserted in order to deal with this. She had the tape inserted. She had problems from the first moment, really, after not recovering from the surgery in terms of infection, in terms of what she subsequently believes to have been an immune system response, but in particular with the mesh eroding and extruding, as is so often the case for women. When she came to see me, she was a woman who, someone whom you looked at instantly and knew that they were unwell. She was grey, she looked 20 years older, truthfully, than she was, and she was clearly someone who was in constant chronic pain. I've subsequently helped her have that mesh removed through a surgeon in South Wales. This is several years ago she's had it removed, and she is a transformed woman. She still has some pain, but the degree of discomfort she lived with has been dramatically reduced. She looks dramatically different. Her colour, her demeanour, her posture, they're all improved. She's been saved, as it were, and made younger by going through the removal. I give you that full anecdote because I think that is an absolute classic case of someone living with this problem. The other thing that was totally classic about her case was that when she went back to her original surgeon in GP, the GP understood nothing about mesh, didn't really understand the procedure, certainly didn't think there were any problems associated with it, couldn't imagine the sorts of pain in groin and legs and abdomen that she was experiencing might be related to surgical mesh. And when she went to see her surgeon, initially was told that there was absolutely no way and this could be anything to do with it, that the complication rates were extraordinarily low, that the NHS and others reckoned that there was only maybe 1 to 3% of people who might suffer these sorts of adverse reactions. And she went through various other tests until eventually a different surgeon agreed to remove it, and we've seen the results. Her example, I think, is but one example of thousands of women in our country and millions of women all over the world who've had surgical mesh inserted and found complications like these. I think this is a medical scandal, and I think there has to be, and I'm so delighted the review is looking at this, some acknowledgement and exposure of the scandal and acknowledgement of the fact that this has come about. The reason it's come about, again, I think is actually quite straightforward. Stress-related incontinence for many women can be, very problematic and make lives very difficult. And therefore, there have been operations being provided for women, autologous sling colpo suspension over many years, in order to try and deal with the problem of SUI, in particular in women after childbirth in middle age. Mesh came along in the mid-90s, effectively, and was perceived as being a very quick, very straightforward process. It was day surgery as opposed to the 4-day inpatient surgery, which obviously required much greater recovery time, etc. for women to undergo. Therefore, there was both demand from women to have this surgery undertaken because it was so much easier and because it was being described by the doctors as so much easier, and there was a big push from the device manufacturers through the GPs and in particular through the surgeons, obviously, to undertake procedures using mesh. I think consequently what happened is there was a very wide take-up, dissemination of this particular technique for prolapse, but in particular for SUI, and in our country, but also in France and Italy and Germany and other, you see a similar take-up curve in a similar period of time in the 1990s and in particular early 2000s. And frankly, far too many women with at far too young an age, and often with quite limited conditions, certainly conditions that didn't really require this degree of intervention, had this intervention. And I think for and therefore what subsequently happened is significant numbers of those women found that they experienced problems, chronic pain in legs, abdomen, elsewhere, debilitating condition that left many of them with absolute changed lives, unable to work, unable to pick up their children, unable to have sex. These are dramatic, life-changing shifts in their lives. And I think the most scandalous thing, other than the overselling and indeed misselling, in my view, of the procedure, was the extent to which the medical fraternity in our country, but around the world, then essentially denied that there was any evidence that there was a significant problem emerging, stuck to the line that there was only a very small number of women who experienced any serious complications, and essentially defended and denied all of the anecdotal evidence that was emerging not just in our country but around the world. By illustration of that, when I first sat down to meet with health ministers and representatives of the NHS and the MHRA in our country, I think 4.5 years ago now, a meeting with ministers in the current government who I think have been excellent at pursuing the truth in respect of mesh and trying to get to a better clinical position in respect of it. But in those first meetings, the MHRA in particular, but the NHS to a lesser extent, were completely defensive and totally stuck to the line that only between 1% and 3% of patients in the NHS in Britain experience significant problems after having mesh implanted. Now, this was in the teeth of emerging evidence, so the Kelty report in Nature, but other evidence too that was emerging from around the world. And indeed, there was evidence that the NHS was starting to shift its position, both in terms of the volume of mesh being implanted by surgeons, I suspect in direct consequence of the volume of anecdotal evidence that was emerging from around the world, and then progressively you saw on some of the literature being produced by the NHS a shift in the degree of risk they were admitting. So at first it started saying 1% to 3%, then it became 3% to 5%, and now of course we understand from subsequent pieces of analysis that have been done that it's significantly higher than that. I suspect it is higher than the 10% revealed by Kelty. I think if you look at some of the other studies, notably the analysis done by Keith Willett's team of the HES data and the volume of women going for outpatients for a variety of different problems post mesh surgery, that indicates to me that this is a significantly higher number than we previously recognised. So what does this leave us with now, as it were? Well, I think it leaves us with a number of unresolved issues. One is that the status of mesh in the NHS is still, I think, disputed and debated. and the way in which this review has been announced, and the pause that I think you so excellently introduced so rapidly after you first started looking at this problem, was announced. Both good things, but the lack of grip to get that aligned, I think, with the NICE review and the subsequent NICE guidance that came out recently is, I think, problematic, and has left surgeons to whom I talk slightly betwixt and between as to what they ought to be thinking about mesh. So they know that they oughtn't to be deploying it in women now, but they wonder whether the pause will be lifted, and whether it will be lifted so as mesh might be used in line with the NICE guidance. Of the NICE guidance, I will say a couple of things. One is that I think the opacity of the NICE process as far as patients are concerned, and indeed other interested parties such as parliamentarians, is something that needs to be thought through, and frankly we need a greater degree of transparency as to how they arrive at their decisions. The best illustration of that in respect of this is the reversal of the decision to deploy NICE in prolapse, because in the previous NICE guidance it was recommended that mesh oughtn't to be used for pelvic organ prolapse other than in research only, which is code in the NICE world for don't use it, because there is no research being done in our country or indeed anywhere in the world into the use of mesh in pelvic organ prolapse, and everybody knows that. So don't use it in other than in research is doctors' code for don't use it. But in the latest piece of guidelines, they reversed that decision, changing it to it being okay to deploy mesh for pelvic organ prolapse. Now, it may be that they've got new evidence to show that, but the reality is they don't. There has been no big study, or indeed small study, undertaken in the intervening period, and there is no attempt in the NICE guideline to illustrate why it is they reversed that decision. Equally, in respect of mesh's use for SUI, stress-related urinary incontinence, there is effectively a change, certainly in the language around its deployment. Effectively, what they recommend in the new guideline is that it is deployed third line after more conservative treatments, i.e. physiotherapy in the first instance to try and strengthen pelvic floor muscles. Secondly, looking at alternative surgical interventions that might be undertaken, colpo suspension, autologous sling being the two most commonly practiced, although we have a big problem there because the number of surgeons able to undertake those interventions now are very few, so we're going to have to retrain people if we're going to see more of those interventions. And then third line, effectively, it suggests that mesh could and should be used. But there is, I think, to some extent, a denial of responsibility by NICE to say something more definitive about the risks and benefits associated with mesh. And their argument, I know, would be to say, well, look, we can only work with the evidence, and our job is to review the evidence and then make recommendations. But in reality, they are looked to as more than just that. They are looked to be the arbiter of what is good and safe and sensible for the surgeons to undertake. And when you have an instance such as this, where there is controversy, then I think we've got to think about a way in which better, clearer advice is provided both to patients, but critically in this instance, the clinical community. And my point is that you've got your review and there is NICE's guidelines. Not ideal. There does need at the end of this to be a full stop and a more definitive perspective put forward by effectively, arm's length government bodies to the clinical community as to what they should do. One of the other things that this issue illustrates is that although we've made huge strides in data gathering and data analytics in the NHS in the last 20 years, immeasurable strides, and we now have HES data and coding, which allow us to see what sort of interventions have been made, etc. This case illustrates just how imperfect those systems are and how poor they are actually at recording problems and picking up problems where we don't initially know they exist. So the vagueness of some of the codings around mesh, where initially there weren't different codes for vaginal insertion versus abdominal insertion, and there weren't codes for different types of tape, etc., etc., and especially where you've got vernacular which is different. So is it a tape, is it a mesh, is it a sling, is it a TVT? I mean, there are different words deployed both by the surgeons themselves and frankly different understandings of, I think, even on the part of the surgeons as to what they're implanting. I don't think it's always the case that the surgeon says, oh, it's not mesh, it's a sling, or it's not mesh, it's a tape, and they don't understand that they are being misleading, but they are misleading. And in some instances, I think that they are deliberately misleading because their assumption is that the evidence doesn't show that there is a problem with mesh, and therefore they are overriding what they believe are misguided or misplaced concerns on the part of their patients. And I think they need to treat the patients sometimes with a little more respect and assume that they understand and can understand and interpret risk far more efficiently than the surgeons sometimes allow, in my opinion. So the data gathering is hugely important. I'm very pleased that your review has already insisted on better data gathering in respect of registry prospectively. I think there needs still to be a really detailed audit done, a retrospective audit, in order to try and get to the bottom of what's happened to people to date. And I think in some respects that is as important as a prospective registry, and I'll tell you why. The surgeons and the patients are already voting with their feet. There will be fewer and fewer women undergoing this procedure in our country and elsewhere, but there's a big bolus of women who've been injured by this, and they deserve both for there to be clarity and truth about the scale of the risk they underwent, and for women who've had mesh implanted and for whom it's not posed a problem to date, they too I think deserve clarity as to the risk that they ran and might still run in the future. And the reason I say that is, although the evidence we all can all agree is that the significant majority of women do not undergo, who undergo this procedure do not have a problem. Maybe 80%, maybe more, do not have that problem. That's certainly what the evidence shows at the moment. It also shows, if you look at, in particular, the data set that Keith Willett undertook for the NHS review, that problems emerge at 5 and 7 years, and sometimes at 10 years, and therefore there will be women out there who've not had problems to date for whom this may eventually pose a problem. So a retrospective audit for them is required. The third reason I think it needs to be undertaken is I do think some of these women will absolutely deserve compensation of some sort. I think they have been injured by this procedure, and I do think that this procedure was significantly oversold and deployed in far too many women when it wasn't necessary. Ultimately, what this is about is women bearing a risk that wasn't justified in terms of the condition they were suffering from. And by illustration of that, I spoke to a very senior surgeon in this field last week who illustrated what he thinks is a change in attitude on the part of the surgeons in terms of the degree of risk they perceive with this intervention, when he asked a room full of male and female surgeons as to whether the women in the room would undergo this procedure using mesh if they were suffering from SUI, and not a single one of them, I don't know how many were in the room, but not a single one of them, he said, put their hands up to say that they would. So I think you'd probably get the same answer from the men if you ask them in respect of their wives and partners or mothers or sisters. And I think that is borne out by the dramatic downturn in the number of pieces of mesh being put into women for SUI in our country and elsewhere. A couple of other things that I think we do need to think about in future. One is what this says about the licensing regime for medical devices. Clearly it cannot be the same as the regime in respect of molecules, medicines. You can't undergo randomized controlled double-blinded trials in the same way for obvious reasons for a device, but the licensing system, I think, for devices is still far too rudimentary. In some instances I think it's like the Wild West. I mean, there are of course famous examples such as testing the extent to which a piece of orange, the fabric from a bag of oranges might pass the test to be perceived for mesh. Now, that's an anecdote, but the reality is that system of equivalence and not having to really go through the same degree of rigorous tests if you are a follow-on producer of a second, third generation mesh. All one needs to do is to demonstrate that your mesh has similar properties and similar efficacies to the original device. That cannot make sense in the 21st century. We do need to come up with a better means of testing and verifying that devices are safe and efficacious. And given that this is such a big growing area of medicine, and given that we can see that there are going to be many more devices for many more sorts of conditions, this is a moment for us to put our foot on the ball, I think, and think about getting a system ready for the next 50 years of development of devices, because the current one just isn't fit for purpose in my view. I think the last thing I would say is that it is wrong that it has taken women to rightly kick and scream and make a fuss about the harm that they've been done, for this to have become an issue of national salience, because the medical clinical fraternity should have realised at an earlier date that this was an emerging problem, that the anecdotal evidence in our country and elsewhere that was becoming ever more clear ought to have triggered an earlier review as to the safety of these devices. And it took political pressure, and in particular pressure from individuals like Kath Sampson and all of the other campaigners with the different campaign groups, to get this onto the government's radar, onto MPs' radar, and frankly to force the colleges and the individual clinicians to think much harder about the scale of the risk. And there is still a gross reluctance, I think, to acknowledge the scale of risk. There is still pushback. There is still a sense, well, the evidence says, it's only 4 or 5%, and it's really small. Frankly, if it is 4 or 5%, that's too many. But if it is 10% of women, of the thousands of women, or if it is 20%, as I suspect it may well be over time revealed to be, then that is an enormous, scandalous volume of harm that's been done by these devices, and unnecessarily so in so many instances. So the system, I think, needs to take a look at itself as a result of the mesh scandal. And I think the women who, very bravely, quite often through the pain and discomfort that they have to endure on a daily basis, whether that's coming to Parliament to take part in meetings, or giving evidence to this review, or making known their issues, their problems in other means. They've been very brave, many of them. One example, there are thousands of them, and many thousands who I suspect have not been able to take part because their lives have been damaged by it. And I think we need to make sure, parliamentarians and clinicians and all of us, that it doesn't happen again in respect of other women for some other reason with some other device. It's a very easy thing, I think, to say to a woman, I've got this really simple procedure, it'll only take 20 minutes in and out, and you'll be able to carry on doing the things you were doing before you had kids, and you had what so many women experience in terms of the changing nature of their bodies. It's just not good enough for women to have to run this degree of risk.
Right, well, thank you so much. That was an amazing exposition of what has gone on and your hopes for the future. I thought it was very interesting you started off with, and we've heard so many similar stories, but everyone is unique, everyone's experience is different, but clearly there are some overall themes, but we will never lose sight of the individual cases and the tremendous suffering that they and their families have suffered. So, talking with great authority, I think it's very interesting what you were saying about the controversy with the NICE guidelines. That's something I think we need to address. The data analysis, and we share a view that HES is imperfect. It's not the most perfect system. Coding needs to be much more accurate. And the misleading language that has been used in the past, we have also heard that. Your wish for a retrospective audit, we need to think very carefully about that. It's clearly an extremely difficult thing to achieve, but it's something that is on our radar. Compensation, clearly other people have raised that. Just looking to the future, medical devices and the licensing system, and you said it was rudimentary. And again, that's an issue that we're thinking about. And the equivalence assessment, and I think your words were, it's not fit for purpose, and that's something that needs to be looked at. And also, of course, your view, very much shared by us, that it's not right that campaigners have had to get this a national issue, an issue of huge importance, but it is really their energy, their determination, their courage in bringing forward individual cases, the experience that they have given to us and indeed to you, that is so important. So clearly we need to think about the future. The future is hugely important, and share your view that we would not want this sort of thing to happen again. How we prevent it is going to be a great challenge, because devices will be coming on stream.
Yeah.
Pharmaceutical companies and other device companies will want to promote what they believe will help people, but it needs to be properly assessed before it's put on general release and is used. So that's been extremely helpful. Thank you very much indeed.
Well, if I could briefly raise two other things that have occurred to me while we were talking, and they're about the present day, as it were. I think there are a significant number of women who've clearly been injured. I know that this is something the review has already addressed, and in terms of the conditions that you put on record as being needing to be met before the pause can be lifted, but the lack of a clear set of signposts to where women go if they have been injured, where devices might be removed, who are the right people to remove those devices, and what sort of care women might need physically and psychologically in some case, is, I think, absolutely essential at the moment. After the initial review that Keith Willett undertook, and I would also like to place on record that I think he's been hugely important and instrumental in getting this onto the political radar. In fact, I think more so than anybody behind the scenes, in taking seriously and putting in place the evidence that was necessary to get this taken seriously by the government and institutions. I think it's it's a shame for Mesh that he's not involved any longer, but I know he's gone on to bigger and better things. But when that initial review suggested, I think, that there were 13 or so mesh removal centres or mesh centres of excellence across the country, I think what it disguised were the very different levels of expertise, volumes of patients between those different centres, and we actually have big black holes across the country where there aren't real experts and there isn't adequate care pathway for women, and there aren't the sorts of multi-disciplinary teams that are required to assess women properly. And then there aren't the requisite surgeons who with the skill sets and the experience to remove the mesh. So I think we've got to come up with maybe one suggestion is that we do need to think about some sort of specially commissioned pathway to deal with the bolus of women who've been injured. Because I don't think it's so enormously great that it wouldn't be possible to come up with a special pathway, as we do for rare diseases and rare cancers, etc., and centralise that to some greater extent. The second thing I'd say about that is I'm a devolver and believe in devolution, but I think this reveals one of the weaknesses of devolution, which is you don't have always the same degree of expertise in Wales and Scotland or Northern Ireland that you have certainly in London and other big metropolitan cities in England, and we don't always have, I think, the seamless working between the administrations and institutions in all of the different jurisdictions across the UK, and we've got to get better at that, because frankly, devolution cannot allow different citizens in different parts of the UK to be getting radically different services from their NHS. They all pay the same taxes, and they all should expect to be able to get a reasonably similar experience, in my view, across the UK. And when you've got specialist conditions such as this, it isn't going to be possible financially or in terms of human capacity to replicate the services in all parts of the UK. So we've got to get better in joining up ministers and their officials to make sure that people can cross borders and be treated more efficiently elsewhere. And I know they would tell you quite often they do that, but there are myriad instances I've come across where there are just so many impediments to treating people across borders, and quite often one part of the system doesn't know what the other part of the system has or does, and equally quite often doesn't know the individuals involved. We're becoming rather more isolated, I think, between different health communities in different parts of the UK. So getting that right in future, and frankly not in future, getting it right PDQ, because these women are getting older and are experiencing problems, and they deserve to have the system respond to them rapidly.
Yes, can I say, we had a very interesting visit to Cardiff and also to Belfast. And we've also heard a lot from the mesh survivors, the Welsh ones, and also those from Northern Ireland. And I think what you've just said is of huge interest. I want to ask you a question about regulators, but before I do, I think, Sir Cyril, did you want to come in?
Well, it was just on your last point, because women have told us about their anxiety about getting specialised services when they live in South Wales, where those services may only be available in England, adjacent, or I guess in North Wales too, where we haven't heard so much from there, but that's also been in the newspapers recently. I'm not sure whether that's within our remit or not, but there are, I think, essentially political questions there that have to be addressed, and I don't know how those would be addressed, because that's beyond my pay grade, but maybe you'd like to just explain that to me.
Well, I'm a former Shadow Secretary of State for Wales and a former Shadow Secretary of State for Northern Ireland, and I was a special advisor to the last Labour government in Northern Ireland, where we were dealing with some also thorny health problems. The system is devolved, and therefore there are Chinese walls and segregation between the different health systems. However, there have always been instances where there has been specialist commissioning pathways, recognising the fact that you won't have always all of the same or all of the top machines or surgeons or capacities in all parts of the country, and therefore there has to be a way to signpost and get women to be seen in the right places and by the right people. Translabial scanners is a good example in this instance. I don't think there's one in Wales. Now, I know a lot of surgeons now have the view that that is one of the most effective way that we might determine whether mesh is the cause of a problem that a woman is experiencing. I don't think there's one in Northern Ireland, but there are several in England. Now, I know that women are finding it hard to get referred to be scanned using a translabial scanner in England. Now, that is a political decision at one level, but ultimately it's about different bits of the NHS working together, because there are memorandums of understanding that have long since been signed that should, in theory, not make that a problem between health ministers. But quite often it's at the sort of operational level that people run into the brick wall, and sometimes it is because the surgeon in country A won't know that the systems in respect of country B. And if you've been a surgeon in Wales for the last 25 years during a period of devolution, you may not know where it is you might refer someone to have a translabial scan in England. So ultimately there has to be some centralised.
So the administrative systems necessary to refer to enable smooth running of that referral system are in place, are they?
Well, the political system certainly is there, in as much as there is a memorandum of understanding signed between all of the health ministers across different parts of the UK that is meant to facilitate cross-border treatment where appropriate and where necessary. I think what is probably required in this instance is there needs to be, by NHS England, some thought given to what the optimal care pathway is for women who've been injured, and that then there needs to be dissemination of that and opening up of that to women in other parts of the country where they won't be able to develop a similar and perhaps similarly excellent care pathway because they simply will not have some of the requisite individuals or kit. NHS England has to take a lead, and in reality that is what's been happening. NHS England has been in the lead in respect of thinking through what the care pathway looks like, although Wales and Scotland and Northern Ireland were perhaps a bit quicker to spot some of the problems and quicker to respond, I think, to the women's concerns, which may say something about the benefits of a smaller scale of health provision, but equally there are disbenefits which are about capacity. So I don't think it is in your remit to fix that, obviously, Cyril, but I think it might be something, given that you've taken evidence from all around the UK, that you might reflect that effectively the sorts of specialist care pathway provision that is undertaken for specialist drugs or specialist interventions, people coming for certain cancers to London, for example, might be undertaken in respect of mesh removal for women, so that they know exactly where they're going to go and to whom that they're going to see somebody who really knows what they're doing. Because the other problem, and let's be blunt, in some of the centres of excellence that have been listed, the surgeons who are the experts are the one who put the mesh in the first instance. So it's not inexplicable that the women then don't feel terribly comfortable by going back to go under the knife with the same person. So getting that right, I think, would make sense.
Thank you.
Now, we have been to Scotland too on 2 occasions, but of course they have a stronger devolution aspect in terms of their parliamentary system. Can I just ask you about the regulators? Have you any views on the regulators?
Yes, I worked in the pharmaceutical industry before I was an MP for a period, and I think the reality is that medicines regulation in our country has largely been I wouldn't say a rubber stamping exercise, but we've been part of a very centralised European system for a long period now, and the role of the MHRA therefore has been very often, not always, but in most instances, to say yes to things that the European Medicines Agency has approved. So I wonder whether our MHRA has been as robust as it might have been if it were undertaking these things without external guidance and a European level of scrutiny and approval prior to medicines being marketed or available for marketing in the UK. So I think post Brexit, if we do Brexit, one of the things that ministers have got to get right is strengthening the MHRA in order to reflect a greater degree of independence. But on the issue of devices, I think the MHRA is reflective of regulatory authorities all over the world, which is that they are behind the curve in respect of medicines. And I think there has been a bit of I think there's been complacency, and on the basis that there is kind of a widespread, not unreasonable initial assumption that you can't have the same degree of pre-marketing scrutiny for medicines as you for devices as you have for medicines, for the reasons I described earlier, and an assumption that the degree of risk and the level of harm that might be inflicted on patients through devices is that much lesser than medicines, which again is not traditionally an unreasonable thing to think. But when devices are becoming more and more invasive and more important in respect of preserving life, and bigger interventions, and I'm not just talking about pacemakers, but other ways in which the brain and the heart might be stimulated electrically or in other by other means, or implanted medicines. There are hybrid medicine and devices we're seeing developed all the time now for diabetes and other things. The truth is the medicine that is being implanted will have been subject to dramatically more rigorous testing than the piece of plastic that's stuck in the arm for these diabetes, for example, interventions, and that can't be right. And therefore there has to be a better, I think, set of standards and regulations that apply more computer-based testing, more in silico testing, as they put it, a greater onus on the companies to undertake as rigorous a set of clinical trials as they can. You can't obviously replicate it, but as rigorous set of clinical trials as they can. And crucially, and I think this is the really key part, a much bigger onus on the companies bearing the cost and the and implementing proper post-marketing surveillance. So they are monitoring exactly what their devices do, not just initially but over time. The truth is that the devices companies have essentially deployed what is quite called fire and forget. They market their product, they get their product developed, they get it on the market, and then they market it to people. And after that, not their problem. After that, it's the clinician's problem, and that has to change. There has to be a greater emphasis, I think, on their maintaining databases and registries. Now, some of that stuff is being resolved for them centrally by the introduction of kite marks and data which will be able to identify RFID systems, etc., identify whose device is in which patient. But frankly, they will, I think, need to do more in future to take greater responsibility for these devices if they are going to market them as widely as we anticipate they will in the years to come.
Thank you very much, Sam.
Well, I was going to raise a sort of linked point. So these devices, such as mesh, are designed to be implanted in the body for life. That's the purpose of them. And as you quite rightly pointed out, it's very difficult to provide pre-authorization, pre-licensing R&D that demonstrates safety. So my thinking is around the consent process. When a woman or a person in the future, not just necessarily mesh related, but someone who's considering such a device is being consented for that, how do you achieve informed consent? Because does the system, does the clinician or the regulator or both need to in some ways be clear about what they don't know about the long-term, lifetime impact of having this device inside you, as well as what they do know from pre-market testing and the surveillance, post-market surveillance you rightly pointed out. So does there need to be that what we don't know consideration, and if so, what impact does that have on the individual patient?
I think that's a really good point, and speaks at some level to the heart of the problem we've had with mesh and the acknowledging recognition by the clinical community of the problem and the scale of the problem, because the system is predicated on the evidence, and the surgeons not unreasonably say, well, the evidence shows that this is safe and efficacious, and indeed the evidence shows that there's only a 1 to 3% complication rate. What the evidence doesn't show quite often is what the complications are, and more importantly, when there is no real financial incentive to undertake intensive, or indeed arguably any R&D or clinical studies in respect of devices once they've been licensed and are on the market, then you've got always a dearth of evidence. So part of the problem with mesh then and now is we haven't really got enough evidence about its effects. We're all still making some assumptions about its efficacy, and critically, what proportion of women undergo problems and how serious those problems are. And there is no real financial incentive for any of the device companies, or indeed the NHS arguably, because they are potentially disincentivized themselves from undertaking research that would prove that there have been problems as a result of the insertion of mesh. So you've got a fundamental issue there about evidence. In respect of, so I think the point you make that should people be told what we don't know, as opposed to simply being reassured that the evidence shows that things will be well, is a really good point, because in this instance I think a more appropriate and respectful consenting process would have said to women, look, you got this problem, only you know how serious it is. There are 2 or 3 ways in which we can try to resolve it. But the first instance, physiotherapy is clearly the way in which they would recommend you undertake it. But there are then 2 or 3 different ways in which you might undergo a further, more invasive process, and these are the sorts of benefits and disbenefits of each of these individual processes. And crucially, as you say, long-term effect. Mesh should be a good example. You'd have to admit that copper suspension and autologous sling quite often don't work, and may stop working after a period, and are more difficult to recover from, and do lead to greater pain post-surgery for a greater proportion of women. So you need to be honest about that, but equally you need to be honest that there have clearly been very many instances, we don't know precisely how many, where women have encountered significant problems with mesh too. So yes, in principles terms, I think the key thing is doctors need to treat women and men, but women in this instance, as able to assess risk more efficiently than they allow. Again, this is a debate that's been had in the medical fraternity forever and ever and ever. You know, how do patients, individuals without medical knowledge, have an adequate sense of what risk is? And I think my observation is that people actually, in common sense terms, are pretty good at assessing risk. And the common sense way to describe this is, if you said to a lot of women, look, you've got a problem with incontinence when you're engaging in an exercise class or going jogging or dancing or whatever, because your pelvic floor is weakened post-childbirth, and that's probably going to go on for a long period, and you could have this intervention, but as a result of it, there's a risk, let's call it 1 in 10, let's call it 1 in 100, that you are going to have chronic pain for the rest of your life and not be able to have sex. Then how many women do you think, if it were put to them like that, would say, well, I'm going to go ahead with that? I suspect very few, and I suspect that isn't how it was ever put to women, which is why we've got this problem.
Thank you very much.
Well, it was just really to go back to a point that you raised earlier about the opacity of NICE guidance and guidelines. And indeed, I think it is a problem, and one that we are actually in conversation with NICE trying to resolve, because you raised the particular point about the research restriction for women who would be treated with mesh for anterior or posterior vaginal wall prolapse. And I think we have all been under the understanding that that had been lifted as a result of the new guidelines, which don't make any mention of that. I am in conversation with NICE, and my understanding is that the old guidelines still exist. They have not changed. They have not been withdrawn, which is slightly confusing, to say the least, for all the women, because clearly people have been under the impression that it was lifted.
Yeah.
And I suppose. So as I say, I'm in conversation with NICE to just tell me chapter and verse as to whether it still stands. Does that just make a huge difference?
Yeah, look, one of the things we argued as an APPG from the first moment we were formed, and that is because we respect NICE greatly, and they do, I think, excellent work most of the time, and they are hugely respected all over the world for the quality of the work they do, and I think they are a vital arm of the state in terms of giving doctors a sense of not just the cost efficiency of medicines, but the efficacy and safety of medicines too. But they are opaque, the way in which they go about things, and the thing that was initially deeply irritating is that they refused to bring forward the time frame, or they refused point blank until they eventually did, for this review, even though this controversy was sort of on fire all over the world. NICE's attitude was, we've got our schedule, and the schedule says, I'm afraid we're not looking at it until March in 2 years' time. So the computer says, no, there's nothing we can do about it. And that struck me as completely bonkers, frankly. And then when they do produce this, they produce it sort of alongside your review. And as I said earlier, I think it was very confusing as to what it was they were saying. I also think they play a bit of politics in this, because if you look at the press releases that they put out around this, I think that there was there was a bit of politics played with that as well, as to what they were saying. Were they suggesting that they were in line with you and this was being paused, or was there no change at all and it was exactly the same as the previous set of guidelines on SUI? That always said effectively it was third line. I just think they need to be a bit clearer. I'm sure that clinicians and Royal Colleges that had been hitherto incredibly defensive of the way in which mesh had been deployed and of the safety and efficacy of mesh, they were no doubt lobbying NICE during this process, informally and formally, with those views. And those views did seem to me to be better reflected in the NICE guideline than the views of millions of women all over the world. Let's not forget, in other countries, the Australian Health Minister has formally apologised to women for the harm done to them by mesh. This isn't a small thing. Other countries have banned mesh too. So this is happening all over the place, and I think the slightly opaque language that NICE uses doesn't help, in particular where you've got something where it isn't just the clinicians who are looking at what they've written, but patient groups and patients, some of whom are, understandably deeply interested and concerned to find out what the guidelines say. I think they've got to think about their responsibility in that regard.
Can I just go back briefly to the issue of the industries where you said they should take responsibility? Are you suggesting, what are you suggesting?
Well, I'm suggesting quite straightforwardly that they need to keep a track of to whom the devices, bluntly, whose devices to whom they've sold their devices. They need, but part of the problem we've had with the registry is that everybody's saying, well, who's going to keep it? Is it going to be one of the Royal Colleges? Well, there's two sort of registries being set up. Should we have a specific central NHS England registry, as we've got in respect of other conditions? Who's going to own the data and who's going to be responsible for it? So, and I think ultimately it has to be an NHS England or NHS UK centrally held official registry. But you're not going to, in respect of mesh, but you're not going to have that for all other devices, are you? And lots of other devices, when they come onto the market, whether it's, whatever, if they're uncontroversial in the first instance, there will be no demand for a register, or indeed sometimes there may not be specific enough coding in respect of those things. So one extra way in which we guard against problems not being picked up over time is that the device companies themselves are under a greater obligation to track and record the people in whom the devices have been implanted, and to keep some sort of further registry. And a simple thing to address it would be that there is some sort of financial responsibility on their part to support device registries that are centrally held, that there is a contribution that they make to the state in order to market their devices in that state, such that that state can then retain a registry. I don't think that's an unreasonable request, and I think it is something I know that's being thought about elsewhere. And there are other instances where similar contributions have been sought from pharma companies to engage in support for the dissemination of their product in a country. This would be a similar mechanism.
I can understand all that very clearly, but it has been put to us that maybe there is some responsibility to those people who have been injured by the insertion of mesh, and people have said to us maybe there should be a levy.
A retrospective levy, you mean, or
well, no, it would have to be for the future, I think, because it would be a levy for the future for when damage.
Well, I think that's a very interesting idea. I mean, look, I think there are.
Would it not be practical?
Look, there are clearly instances that I've read about in court cases in other jurisdictions which indicate that there were, on the part of some companies, a greater degree of understanding of the emerging evidence or problems with mesh. Now, I don't know the full extent of that, and I think that's being tested in courts all over the world. But my gut instinct is that some of those problems, were probably better understood by the companies than they let on. And I would be extremely surprised if those companies weren't monitoring very closely, even if they didn't know exactly, whether it was their device or somebody else's, the volume or problems that were emerging in health systems in different parts of the world. Now, that indicates to me that they have a degree of culpability and responsibility to as corporate citizens, if nothing else, to engage in this process, and not just in respect of the individuals who are bringing court cases, but in respect of the wider group of women who may have been impacted. A levy might be one way in which they acknowledge that, and one way in which they contributed to recompense for women. How that would work exactly, I don't know. I don't know of any other instances of where that's been undertaken. But I certainly think that's something that ought to be put to the companies for them to think about, yes.
Right, thank you very much indeed. I think that's all that we would like to cover, but can I thank you so much? It's been a very, very interesting session, and you've brought a lot of ideas to us, and thank you for that. And of course you speak with huge authority, not only in your work in the past before you became an MP, but having researched this so clearly as the chair of the all-party group. So thank you very much indeed.
Thank you very much. Thank you very much for inviting me to speak to you.
Thank you.